Hello everyone, welcome to Facebook Live. I'm Dr. Sylvia Gustin and this is my colleague, Associate Professor James McAuley.
Hi there.
We both lead the Pain Research, Education and Management Program, short PREM in NeuRA.
Yeah. And we're here to talk a little bit about some of the research that we've been doing and really some of the questions that people have asked us about our research and about pain. So let's get right down to it. Should we get started?
Yeah, I think we should say that we both do research since over 20 years now in chronic pain.
That's
and
right.
You do it mainly in back pain.
Yep.
And I'm in neuropathic pain, so nerve pain. And I'm also I'm a clinician, and
and I'm not a clinician, so I don't know. I never talk to patients unless they're in my clinical trials, and we're very thankful for them. So yeah.
So welcome, and now we talk about some of the questions which clients ask us and which are important in chronic pain.
Yeah.
Let's start, huh?
What's the first one?
First one is, why do we feel pain?
Oof, that's a good one.
Yeah, that's a really good one. Yeah. So perhaps we need to say that it's a difference between acute and chronic pain.
Yeah.
And this is also, so let's start why we feel acute pain.
Sure.
Yeah. So for example, I always say that to my clients, so when you put your hand on a hot plate, then the pain information gets forwarded from your hand to your spinal cord and then to the brain. And in the brain there's the thalamus. Thalamus sits in the middle of our brain, is in the gateway between the body, between our peripheral nervous system, the body and our brain. And then the thalamus, it's like a boom gate, it opens, pain information goes through, it goes to higher centers of the brain, and then this gives us the experience of acute pain. And acute pain is actually something very important because acute pain tells us, oh, something is wrong. And warns us. Yeah.
Well, for me, see, we say it slightly differently than that. So I usually think about pain as something that happens just in the brain, and anything that happens before that isn't really pain. So I think that if there's something acute pain, as you say, which is something that happens straight away. So if there is a potential threat to a part of your body, then some nerve signals become activated, some nerve endings become activated, and they send some nerve signals up to your brain. And your brain has to sort through all of these nerve signals and figure out which are the important ones, which ones do we need to pay attention to. And if there is something which suggests that there is danger, then the brain responds by creating this experience of pain. And that really motivates us to do something. It feels horrible, it's got emotional aspects to it, it just feels terrible, so we want to do something to remove the source of the threat. So that's, I think, generally how we think about it. I mean, we're not different. But
No, and I think also what we learn about that, because what I just said, people, when you have put your hand on a hot plate, you will never do it again.
Yeah.
So acute pain is important because we learn. We learn that how to do the things differently.
Yeah, that's
so
right.
It's really
and the things to avoid, and I think that's really important. Yes. Yeah.
So, all right. So that's acute pain, but we are not here to talk about acute pain, huh?
Yeah.
We're talking about chronic pain. So, what is chronic pain, James?
Yeah. Well, chronic pain is a really difficult one, right? Because this is when the acute pain model, so everything that we know about acute pain, when that starts to break down a bit, because chronic pain is we usually think of that as for pain that lasts for a bit longer than for longer than 3 months, and we also usually think of that as pain that for which there is no injury that may have stimulated this painful episode will have cleared up, so that will have healed. If you think about backs, for example, backs heal. They heal really well. They're very strong, and if there is any damage to a back, or any threats to a back, they heal very quickly. So if you have pain lasting longer than 3 months, it's gone beyond its biologically useful purpose. So what is it? Well, you can define it in terms of just its duration. It's longer than 3 months. Why do we get it? Well, that's the kind of big question. We don't really know the answer to that, and we are trying to investigate that. We have some theories that we are testing at NeuRA, and treatments that we have, newly developed treatments that we think we can help people with chronic pain. But the really big question facing all researchers in this area is what is chronic? Why do we get chronic pain? Why does pain not clear up for a certain proportion of people who develop back pain, for example?
So there's one theory, and one theory is that particularly because of changes of structural, functional, and neurochemical changes in the thalamus, and the thalamus lies in the middle of the brain. Because of these changes, people can't get rid of their pain. And this is what I've said before about when you put your hand on a hot plate and the information gets forwarded to your spinal cord and then goes to the thalamus, the boom gate is opening, and then you experience pain. But with chronic pain, what we have discovered is that this boom gate, the thalamus is actually open all the time. So and the boom gate is open because of these structural and functional and neurochemical changes. And these changes that generate chronic pain, that drive chronic pain. So it's not, it's very important that we see that these changes in the brain are critical.
And one of the things that we think as well is that, for what we've noticed is that people who have pain for a long time think in a particular way, and they have beliefs about their backs that we think are really maladaptive. We think that if we can help people change the way they think about their pain or change the way they think about their backs, then that can change their experience of pain and ultimately, over time, hopefully cure them, get rid of the pain.
And I think what you said before is so important, that like a wound has healed, the nerve injuries has healed. There's nothing anymore in the body which drives it. But our research showed that the brain is critical. And that's a lot of people actually don't know that. They feel their pain. They feel their pain in the back. They feel it in the face, and they always think, "My God, what is happening here?" But that is acute pain. Chronic pain has changed our brain. It's So what is happening there? So and we really. This is also our program, the PRIME program. We really try to develop novel targeted treatments, which change the brain, which reverse these changes. So this is important. So this is critical. And
I agree. What's next, Sylvia? What's the next question?
The next question is, how does pain affect the brain? But I think somehow we have answered that.
I think so. And some of those chemical changes, I think, are those neurochemical changes and structural changes. I think that's really your research area. I mean, you're a neuroimager, and that's really your career has been around trying to identify what those changes are. So I think that's a really great area. And I think that's what really makes our collaboration quite nice, because I really come from the more clinical perspective. We're thinking about how can we turn these findings into treatments to help people, whereas you're trying to, a lot of your work has been about trying to understand the basic science behind why people still have pain.
And this is very important. We need to understand the basic science, because only when we understand what's going on, we can develop new treatments.
I think that's right.
So, let's go to the next question.
Okay.
What are current treatments for chronic pain? And this is.
So there are lots of treatments. So I've spent the first half of my career, I've been researching, as Sylvia said, I've been researching this area for about 20 years. The first half of my career was spent with a group in Sydney, in which we investigated lots of the treatments that most people go to. If they have back pain, they go and see their physio, or their chiro, or their general practitioner. And they might get something like manual therapy, in which the physiotherapist will press on a sore bit on their back, or they may get some drugs from their GP. So, my first half of my career has been investigating whether or not those are actually effective treatments, and they're not really. They might change pain a little bit in the short term. When I say a little bit, not really. If you're thinking about a pain scale of 0 to 10. Change it by about 1 point, maybe less than that. So the most powerful drug, the most powerful analgesic only reduces pain down to 30%, which is not a lot. And that 30%, so that again, that's a 1 point difference. It's the same as a 1 point difference.
And has so severe side effects. We have kidney
opioids.
failure, we have stomach ulcers, we have so many severe side effects. And that's opioids. It has its place, I think, definitely.
Well, for acute, I think. I think for a few days, maybe even maximum maybe a week or something.
Or we say perhaps cancer. It has its place, but definitely we need to rethink, because it has very severe side effects.
Yeah, absolutely. And people get addicted to it, and the effects reduce over time. In fact, there's even some ideas that the more you use opioids, actually the more painful your condition becomes.
Because you develop a tolerance. And this is the problem of opiates.
That's right.
So
they're not a solution. They are a short-term, at maximum, a short-term give you a break
Yeah.
until you can do something else, right? Something that takes a little bit more effort. For example, exercise.
Yeah.
I mean, it's boring, right? But exercise is the cure for everything, and it actually is currently the best supported treatment for chronic pain. Is that if you exercise, if you're fit and healthy, and you get back to your usual activities as soon as possible, those are exercises the most highly supported. But, and the interesting thing for me, right, is that it's highly supported by evidence, but it still only reduces pain a little bit. What we really want to do in our work is to think about reducing pain much more than the effects you get from exercise, which again is about 30%.
Yeah,
same
I
as
think,
no
James,
opioid.
we need also to mention it's like psychosocial therapies. They are definitely they have their place. They're very beneficial.
Yeah.
But also again, they're not reducing dramatically chronic pain, but they're helping with anxiety, depression, all of these other things.
Because if you have pain for a long time, of course people get psychologically distressed by that. They get anxious and depressed. Of course you do.
Yeah.
If you have this pain, it's for years sometimes. No wonder people get very upset by it.
But so it's very important that we use novel targeted treatments, and this is actually what we are doing here, developing neuromodulation technique, changing the brain, reversing the changes, and thereby reducing the pain.
That's right. And we have a treatment that we're trialling at the moment. It's an NHMRC funded trial. It's called Resolve. And we're looking for people with chronic pain, and we're trying to intervene at the periphery, so at the back, to try and change the way the brain interprets information, the threat value of that information is coming from the body as it enters the brain. And it looks like we're doing quite well with that, so we're very happy. We've recruited, we've recruited about 150 patients, 160 patients out of 270, so we're doing well.
Yeah, so if somebody wants to take part.
Yeah, if someone wants to take part, they contact us through the NeuRA webpage, or they email us at pain@neura.edu.au.
Thank you very much for joining us on Facebook Live, and if you have more questions, please write them, and
we'll try and get back to you.
Yeah.
Yeah, thank you.
Have a nice day.